Hello, hello, everyone. I am Joe the Science Bro, and today we are continuing with our series called Science Talk. Today I have a wonderful researcher who answered my request for people to come on to the show, and that is Dr. Nicol Joseph. I greatly appreciate her joining us today. She is a geriatrics doctor, which for most of us we don't really get to see those doctors until a late stage. So I think that this will be a interesting and fun time for us to actually be able to discuss certain topics that we really don't deal with until we're at the end of our term, if you will. So with that, I would like to introduce Dr. Joseph. How are you? And thank you so much for coming on the show. We greatly appreciate having you here.
Hi, Joe. Thank you very much. Thanks for having me on your show. I appreciate you inviting me to come on, and I would love to spend some time with you and your audience.
Thank you so very much. Dr. Joseph, if you could you describe a little bit in more detail for us what it is that you do.
Sure. So primarily, I'm a physician. I'm a
Hmm.
geriatric physician, and like you said, geriatric doctors, we take care of older adults, and that's from age 55 and above. Although
Hmm.
most of my patients probably range in the more 60 to as old as 111 years old
Hmm.
right now. Um, and I also do some clinical research here at PCOM, as well as um, teach medical students, residents, and I'm the program director of the Geriatric Fellowship also.
Okay. So what is involved necessarily in geriatrics? I mean, we always hear that term. We never really think about what it actually means. So what does geriatrics actually mean?
Yeah, so really what we do as geriatric physician is optimize care for older adults.
Hmm.
Essentially, my focus is preventive medicine.
Hmm.
So focusing on how can we live to as old as possible for as long as we possibly can and be as healthy as possible to during that time. I think
Right.
a lot of what we do in medicine is what I like to call reactive medicine, where people have medical problems and then we try to find a solution to those problems. We try to fix the problems. But I do a lot with my geriatric patients on how do we maintain health in old age.
Hmm.
When we do have those medical problems, how do we treat them and how do we optimize our health? Unfortunately, we do have patients who are at the other end of the spectrum.
Hmm.
And I also do, in addition to geriatrics, I'm also boarded in hospice and palliative medicine. And we also have that part of it that I also do
Hmm.
with my geriatric patients. But my big goal really is that preventive health for older adults and making sure that they maintain and optimize their health for as long as possible.
Wonderful. So when we talk about geriatrics, I mean, it always seems like we're talking about that end stage. You only have a few more years left. And you're from what you're describing, it sounds like you're talking about trying to take someone and almost accordion that time out as far as possible. How does one actually do that? I mean, obviously there's a compassion and empathy level to it, but exactly how does one give somebody more time, if you will?
So I don't know that it's about giving more time per se, but
Mm,
more so the quality of life that we
mm,
have. So whatever time we have left, whether it be 20 years, 30 years, 10 years, but improving your quality of life in whatever
mm,
time you have. So, exercise for older adults, making sure we promote healthy living in terms of what we eat, um, in terms of, how do we exercise our brain, whether it be doing things like puzzles or reading a book or doing exercises just to maintain your health.
mm,
So whatever time we have left, maximizing our functional function during that time,
mm,
really maximizing functional status for older adults. So for those of us who like walking, you know,
mm,
go walking. Um, for those of us who have chronic health issues, maintaining our blood pressure, diabetes control, all those things, those are the things really that help to maintain health for older adults.
mm. So, um, now this may come as a shock to many people, but I am a white American male, and I have no frame of reference whatsoever as to what it is like being a minority in this country and in terms of healthcare. What exactly
Mhm.
is it like to serve minority communities? Because I know that you're involved in the diversity office that we have at PCOM, but
Mhm.
how is medical care different for, let's say, someone like myself versus someone who is in an underserved community?
So I don't know that it should be different. I
Mm,
think a lot of it is access to care.
mm,
In some of our underserved communities, the access isn't not necessarily that it isn't there, but it's just not as prevalent.
mm,
Um, as far as serving minorities, I'm a minority physician myself,
mhm,
but really, I think it's making sure that all individuals, no matter who they are, have proper access to medical care. have the medications that they need. Unfortunately, I work with patients who a lot of what we call the social determinants of health
Mm,
affect them. So patients who are diabetic, who can't afford their diabetes medicines,
mm,
or patients who, because they live in food deserts, they don't have access to, say, like some of us have access to our Whole Foods or to the
mm,
farmers market. So where we can get fresh um, vegetables, fresh fruit. So some people don't have access to those things. Transportation, they may not have access to transport and things like that to get to their doctors or their specialist visits.
mm.
So I think the bigger issue is really just more access to care, and that making sure all individuals, no matter who they are, have that proper access.
I see. So what I know that there's generally a financial difference
Hmm.
for many different communities. I don't know if you yourself have seen the impact that different financial burdens have on different communities, but I would think that in the geriatric community, you're going to see almost all types of financial situations. How we always have this misconception in the United States that those who are really rich get the absolute best health care ever. Is that actually true?
I don't know that that's true necessarily because I don't know all individuals in the United States.
What?
But
No, impossible.
right, impossible. But what I will say, especially with our geriatric patients, is those who have less, they
Mm,
do struggle more with certain things.
hmm.
So, in terms of their medications, for example, in
Yeah.
terms of, the food that they buy, it's a lot cheaper probably to buy, say, a candy bar than it is to go out and get fresh fruits and vegetables. Um, and I have seen, situations where people have to choose. Somebody
Mm,
might have for example, they may have a cat and they have to choose between, do I buy it for myself or do I buy it for my cat? Because they're on limited income,
hmm.
especially our older adults, and they have to make choices every day. What do I spend on? Do I spend on food? Do I spend on medications? Do I spend on clothes? Do I spend on my rent? Things like that. We've had patients who unfortunately come into our facilities and they're homeless
Mm,
and on discharge, they don't really have anywhere to go, which means that they now have a protracted nursing home stay or a protracted
yeah.
hospital stay because we're trying to find somewhere to place them, so to speak. um, or those patients have to be discharged to what we call a personal care home or a homeless shelter or something like
Mm,
that. So I do think that the low income individuals, it does negatively affect them because I also see that a lot of them come in and they have a lot of medical problems, and those medical problems are either neglected. So for example, something like diabetes, we can't cure diabetes, but we can
right.
certainly what I call palliate the symptoms, meaning that we can treat it. We have medicines that we can use to treat our diabetes. But because that person can't get their medications or they're not able to afford it,
Mm,
then now we see them come in and they have end organ damage from diabetes. So they may have an amputation of a toe of their toes, or they may have kidney disease, which is related to their diabetes, or
mm,
they may have retinopathy, eye problems, which
mm,
is related to their diabetes also. And we don't think about it because every aspect of your health affects every other part of you.
mm.
So just because you have high blood pressure, and I've had people say, "Oh, it's just a little high blood pressure." There's no such thing as a little pressure.
Yeah.
We have to treat it.
Hmm.
So,
So, in the United States, there's obviously, as you said, there's a lot of pressure that, especially socioeconomic pressure, that seems to be on patients. It seems as though, at least from what you're saying, that it would suggest that we would see our geriatric patients have um, some significant blood pressure issues, some
mhm.
significant stress related issues. So, how common do you see certain types of, let's say, diagnoses amongst geriatric patients?
For geriatric patients, I will say for the ones who live to be very old,
Mm,
believe it or not, I see less medical problems. And that's probably why they've lived to be so to be very old. I
hmm.
just had a patient who died. She was 112 years old.
By
And
God,
I'll be honest, she had very little medical problems.
jeez. I wish I hope I get to that point. Maybe.
Maybe it depends on how debilitated I am. So, but it's a blessing. It's a blessing to make it to old age, and for a lot of patients, it really is a blessing for
Mm,
them. But I will tell you that I've had patients in their 60s who have a lot more medical problems.
mm,
And the ones that I have who in the nursing home, for example, who are a lot younger in their 60s, they usually have three, four, five medical problems. And a lot of it also stems from how did we take care of ourselves, how we took
mm,
care of ourselves when we were in our 20s and our 30s. So if you're diagnosed with diabetes at age 25 or 30 and you never took any medicines, you ate whatever you wanted, you didn't exercise, and things like that, then at age 60, you will see end organ damage from from
mm.
diabetes. Or if you're a heavy smoker and you smoked every day, one pack per day from age 12, which I do see a lot of that in my patients, then at age 60, the probability of developing end stage lung cancer
Mm,
is very real. So, we do see a lot of chronic medical health issues in elderly patients.
mm,
And unfortunately, a lot of times when we see them, they're usually the sickest of the sick. We have five, six medical conditions that we're managing. And
mm,
when they come to me, sometimes they're on as many as 20 to 30 medications. And one of the things we do is actually work with our patients to say, okay, can we eliminate some of these medications, especially the ones that aren't really necessary, the ones that aren't really helping? Or
mm,
it might be that they have a medical condition and they're prescribed one medicine, and then they have a side effect from that medicine,
mm,
and they're prescribed another medicine to treat the side effect of that medicine. So
mm,
really critically looking at what's going on with the patient. I'm an osteopathic physician, so one of the things we practice, what we call that whole patient care,
mm.
where when you come in with a medical problem, it's not just that one thing. It affects every part of you. So looking at the whole person critically and making sure that we address their health issues from that angle.
Yeah. So, how s- this is probably going to be a difficult question. How has our geriatric care in terms of the greater medical community changed over time from, let's say, dealing with the current problems that the patient has versus preventing potential problems down the line?
Yeah. So, um, I think to answer your question, I think most of preventive health really
Mm,
should start in our younger years. It
mm.
should start in childhood. And I think if we do a lot of that when we're young, which is hard because, when we're young, we're indestructible. And,
Look, my
right.
warranty ran out a few years ago.
Yeah.
Things just keep going wrong.
Things keep going wrong. But when we're young, we get back up and we're like, I can do anything. I can conquer
Hmm.
the world. So we don't always think of those consequences when we get older. So unfortunately, by the time we get to age 60 or 65, we do
Mm,
have some of those chronic health issues. So a lot of it really has to do with preventing further chronic
mm,
health issues by making sure we manage the ones that we have now and adapting lifestyle changes so that we won't have further progression.
mm.
Again, death is inevitable, so it's not
Yeah.
something that we'll ever find a cure for or we'll ever be able to prevent.
Oh, come on, Dr. Joseph. You got to tell me that you've got some secret sauce hidden in a cabinet behind you.
I wish there was a secret sauce, but apparently there's, and even if there is, I'm not sure that I'd want to take it.
So,
Uh,
um,
but yeah, but definitely preventing debility,
yeah.
uh, no matter how long you live.
So how does patient care change? Um, uh, how does patient care change when you get to, let's say, your 50s and 60s versus, let's say, when you're in your 30s and 40s? Because you're saying we're switching to a more preventative type, almost we're putting that pause button on the health problems that we currently have. So how does patient care evolve or change as you get older?
Well, I think as we get older, again, when you're younger, I think you should still focus on preventive health.
Mm-hmm.
Um, when you get older, a lot of what you're doing also is one, managing the active problems that you have right now. So a lot of older adults might have high blood pressure, they might have
Mm,
diabetes. Some people may have suffered from a stroke. So again, we're managing those health issues, and hopefully patients will take the medications that will help to prevent further organ damage. And again, nothing is 100%, but that's
mhm,
what we're trying to do. And at the same time, what we're also focusing on is, if you're at 65 years old and you're not a diabetic, implementing healthy lifestyle changes so that you
mm,
don't progress to that point where you become a 65-year-old diabetic. So I think preventive health can happen at almost any age.
mm.
In a way, we can do things to prevent health. Again, we're not going to prevent every single thing, but we
Yeah,
could, because, and of course, some of it is genetic, which we have no control over that.
right.
But the environmental factors that we can modify to
Mm,
modify those factors. Also, in older adults, we focus a lot on functional status and maintaining function for as long as possible. So that older adult who's able to get up and go every day, get up, go for a
mm,
walk every morning, come back home, go to the store with their friends, as opposed to that older adult who's bedbound, lying in bed, they're going to have a much better outcome
mm.
um, than the one who's lying in bed all day.
So I already have a question here from our audience for you. Have you seen any correlation between retirement age and life expectancy? I've long quoted the Boeing study that postulates a direct reduction of life expectancy for every extra year of work, but he also recently learned that the Boeing study is apocryphal urban myth.
Yeah. Huh. So correlation, I will, as a physician, I will say that doctors tend to work way past the age of the average population. So
Mm,
it's not uncommon to see doctors over the age of 65, in their 70s, some of them even close to 80s working. um, I don't know that there's I mean, there might be a correlation. I don't know the answer to that question.
mm,
But I know that staying active for as long as you can
mm,
does improve your functional status. There is some correlation between gait speed, for example, and life expectancy.
mhm,
So the faster the gait speed, the longer the life expectancy. And
mm,
working kind of does that. So I think even in retirement, um, if we remain active, that's a big plus.
mm. I have another question for you, and this is a little more hypothetical. So you wouldn't want to be immortal if you could be, assuming no degeneration and no loss of brain power, that is.
No,
Fair, fair enough.
I wouldn't. I don't know that I need to be.
Hmm. So, Dr. Balin and I have long postulated because, as our audience knows, Dr. Balin is in charge of the Center for Chronic Disorders of Aging.
Hmm.
He and I have long postulated for a while that there's a link between activity and long term health. And I've seen it in a
Absolutely.
couple of family members and a couple of patients that I've interacted with over the years. That as soon as they seem to stop either being physically able to be active or they lose that drive because now they're retired and they're supposed to sit on the chair all day long, their health kind of takes this nosedive. Have
Yeah.
you seen a similar correlation to that?
Yeah. In geriatrics, we say motion is lotion, you know?
I like that. I might steal that.
Yeah. And the more you keep moving, the better it is.
Mhm,
So I do think that the more active you are as you age, that does correlate with life expectancy.
mm,
Also, and in a lot of ways, because if you kind of think about most of the chronic disease that we have, a lot of it is related to a sedentary lifestyle.
mm,
So one of the big problems in the United States, for example, is obesity,
yeah.
which can lead to a number of different diseases: high blood pressure, diabetes, metabolic syndrome. So, all of those things, I definitely think keeping active is a big part of longevity.
So maybe you can shed a bit of light on this because we see on TV tons of commercials aimed, especially during the summertime, aimed at senior citizens for different drugs, different different life insurance policies. Why are we targeting our senior citizens so much? Is it because they don't seem to have access to all of their information, or is it because we don't really properly prepare people as they're getting close to that senior citizen level of age?
I think there's a couple reasons. Um, for one, they're home and they're
Mm.
watching television if they're retired. So that's a big population, and you want to reach as big an audience as possible.
Mhm.
Unfortunately, there is a lot of fraud
Yeah.
that the elderly are subjected to. I've had patients myself who came into the office and told me that they've been victims of different schemes and things like that. Um, I think education is a big part of it,
Mm.
educating not just older adults, but younger adults as well, but also for older adults, educating them on their health, educating them on their on healthy lifestyle.
Mm.
Um, you know, could there be more programs available? Yeah, there's also a lot of programs available at the area agency on agents. So,
Mm.
for older adults who have questions, they can always call their area agency on agent and they can provide them with a lot of information. So I think you're right. A lot of it has to do with education.
Mm.
And unfortunately, we do have a lot of programs and a lot of um, insurance schemes and medications that's targeting older adults.
Mm.
Some of them are legit and some of them are not. Some of them work, some of them don't. But I do think there is a lot.
So, obviously, we all just got through a pandemic.
Hmm.
How has geriatric medicine changed since the start of the pandemic, during the pandemic, and now that we're several years kind of past? I don't want to say the worst of it because it's still going on, but
Yeah.
several years past the major quarantine period. Did geriatric care kind of evolve through that? Was it a quick response progress, or was it something that you guys kept hitting roadblocks and you just had to adapt?
So, sadly, we're still in the thick of it, and our
Mm.
geriatric patients are still affected by the pandemic. We're still seeing some of the side effects of COVID. And as you know, the geriatric population was the one that was hit hardest
Yeah.
during the height of the or the peak of the pandemic. I think with anything there was some positives and some negatives. Unfortunately, there were a lot of negatives because we did see a lot of loss of life.
Yeah.
There were a lot of questions surrounding the vaccines and medications and everything else, and there were a lot of myths, unfortunately.
Yeah.
um, in terms of the geriatric population, I think one of the big things and I'm hoping that we will see is more people trained to take care of older adults,
Mm.
because even with presentation of disease, they may have what we call atypical presentation.
Mm.
And sadly, there are only about 6 or 7,000 board certified geriatricians, and there's not enough geriatricians to treat the growing adult population.
Mm.
And even simple things as recognizing the symptoms in older adults. Geriatric doctors traditionally, that's what we do. So we're able to recognize those symptoms. Um, as far as things that have changed, you know, regulations when it comes to institutionalized care and the nursing homes, I've seen a lot of improvements in
Mm-hmm.
infection control in facilities, in hospitals, in nursing homes. I think people in a lot of ways have become more aware,
Mm.
and or geriatric patients especially, I've seen them become more careful where, you know, I see them wearing their masks when nobody else is,
Yeah.
or they're more they actually wants to take the vaccine, the COVID-19 for COVID-19.
Mm-hmm.
They want to take the precautions, a lot of them. And to be honest with you, in our facilities right now, I've actually seen a little bit of a downtick in COVID, as far as the infections, because most of the residents are vaccinated.
Great.
So I think there are some positives that have come out of it.
Hmm.
Telemedicine, for example, has taken off during the pandemic, which has brought access to healthcare to
Yeah.
people in a lot of rural areas, which I think is great. And also access to care for people who might be homebound.
Hmm.
Or practice itself, we have a group that goes out and they do home visits to the home of our geriatric patients. And during the pandemic, that's one of the things that they continue to do. They actually brought vaccines to a lot of people in their homes who couldn't go out
Hmm.
and who probably otherwise would not have gotten vaccinated. I actually used to do a lot of home visits myself early on too in my career, and I still do a couple of home visits too.
Hmm.
But I've seen a lot of, at, in spite of the negatives that have happened with COVID, I will say that I have seen some positive changes that I'm hoping will translate later on into improving healthcare.
Well, that's actually great news to hear because you always hear the negative these days in the news and in reporting and articles, all of that. It's nice to hear some hope
Yeah.
in the geriatric community. And I had COVID myself in January of 2022, I believe it was.
Mm. Yeah.
And it was rough. That was some of the worst 3 weeks of my life. I tell people that because I just didn't have the physical capability to do anything.
Yeah.
I thankfully I wasn't sick enough to go to the hospital, but telehealth really made it easy for me to get in contact with my primary care physician.
Mm-hmm.
I think telehealth has really assisted medicine, in my personal opinion. I think that it's made ease of access a lot better.
I
Um,
agree.
there. This kind of leads me to another question that I have for you, which is how has technology improved geriatric um, treatment and geriatric care? Because my father was a history teacher for 20 years, so from the 1980s to the early 2010s, there was a huge technology difference between that.
That's right.
And, my father used to say that every 5 to 10 years, we go through the equivalent of the Industrial Revolution in terms of
That's true.
technology. And, you know, so there's a lot that's out there, but I know from personal experience as a scientist that new and expanding technology tends to trickle down very slowly to
Yeah.
all levels. So how has technology really improved, other than like telehealth and things like that? How has that improved geriatric treatment?
Yeah. In recent years, and let's see, I graduated medical school in about 2002. So it's been a few years.
Hmm.
But I have to say that I have seen so many improvements in terms of medical treatments, technology, for example, cancer treatments.
Hmm.
We've seen so many breakthroughs over the years. So we had cancers that before were not thought to be compatible with life. Patients are living for 5, 6 years. We've seen advancements in things like immunotherapy and gene therapy,
Hmm.
and even with technology itself. Just to kind of go back to the pandemic, one of the concerns we had with our older adults was, would they be able to use the technology, for
Mm.
telehealth, and would they be able to use the technology for everything else?
Yeah.
And I have to say, they surprised us. They
Mm.
were able to learn some of them. Unfortunately, we were in Philadelphia where some areas didn't have very good, I guess, Wi-Fi or
Yeah.
broadband systems, so it was a little difficult for those patients. But
Just
I
say
was
that a
very
little louder. Comcast needs to hear you.
yes, they do.
They keep
Improve the
touting
broadband.
that they've provided that upgrade to underserved areas. They need to
Yes,
hear that a
yes,
little
they
bit
need
better.
that. They do, they do. Yeah, so, but I was very surprised and
Mm.
pleasantly so. And I said, all the adults, they'll surprise you, and they learned the technology, those who can. So I think not just with telehealth, but in terms of other things, for example, access to my chart where the patients can go in and view their own labs. Um, Although there's good and bad that
Yeah.
comes from that one, because I've had patients go to a specialist and then they see something and they don't quite understand and they come to my office and they're in tears and I
Yeah.
have to say, okay, sit down, let's talk about this,
Right.
you know. So there's good and bad that comes with that one. but also technology in terms of, surgery, for example, robotic
Mm,
surgery, and just a lot of different things that I think have improved medicine. You're right. It is slow sometimes to trickle down. Like, for example, electronic health records.
yeah.
I think we still have a long way to go in
Hmm.
that. I wish with our electronic health system that they would talk to each other. So,
Yeah.
for example, if my patient goes to the hospital, I would love to get an alert immediately in the office. And then that would come, the records would immediately come through to my EHR system.
Yeah, you would
And
think that that would be the norm, honestly,
right,
given the current situation that we live in technology. I mean, just
right.
take what you and I are doing currently at this moment. We're able to engage with people worldwide at
Hmm.
in a live situation. You would
Yeah,
think that there would be an easier ability for people to kind of have that instantaneous communication.
yeah, yeah. That's something that would definitely make medicine a lot easier. And
Mm,
even with, doing care, because I do care in a number of different venues. So I do care at home, I do care in the office, nursing home, I do inpatient hospice care. And each setting has a different electronic health system
mm.
with a different formulation for the passcode. So I have to remember 10
Oh my
passwords
God.
in a given day. So can I just use one password and get through to all the systems? Um, and of course, when EHR was first developed, the focus was really more on hospital and outpatient care. So um, things like nursing homes, home care,
Mm.
hospice, they were a little bit behind also. So I think that's improving, but I think we still have some way to go with that.
So, I know for me, because my background is more. Oh, wait, hold on. We have a question from the audience. Have you seen quality of life differences between patients that live alone with family or, pardon me, at an institution? Is it more case by case, or are there clear benefits to one versus the other?
I think it depends. One of the things we noticed during the pandemic is that patients need socialization.
Mm,
So isolation was not good for our geriatric patients. I remember in the pandemic, I would actually, some of our patients, I would go into their rooms, PPE and everything, and I would
yeah.
just sit there and hold their hands because I knew families couldn't come and they were scared, they were lonely, they were by themselves.
Hmm.
So socialization definitely is important. I think if you live alone without great access to care and without support,
Mm,
and by support, I mean caregiver support, not just formal caregiver support, but family, maybe friends, that sort of thing. I don't know that you're necessarily going to do better than that person who's in a nursing home,
hmm.
because what happens is if that patient who lives alone has a fall, for example,
Yeah.
they could be there for a couple days, nobody finds them. um, if you're somebody who likes the interaction of others, then in some cases a facility might be better for you. I
Hmm.
remember I had a patient who actually lived, I used to see her for home visits, and she lived at home with her son. She was 100 years old and her son was 85.
Mm,
And she said to me one day, she said, "I'm tired. Dr. Joseph, I want to check into a nursing home and I want to live there for my the rest of my life, and I want to have cake and ice cream all day."
mm.
Yeah.
I wish.
Exactly. At 100 years old, you might as well. But we got her into a nursing home, and by the way, I also wanted to mention that her son was blind.
Mm,
And I think she knew she was at the end of her life, and she wanted to make sure that he would be somewhere where he would be taken care of. And since I was her physician, she also wanted to make sure that I would be the doctor taking care of him for the rest of his life.
is that uncommon, actually? I'm sorry to interrupt you, but is that
Oh, yeah,
uncommon
sure.
to happen? I mean, or is that something that happens a lot where you actually get people that are like, no, 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 I want this doctor to come and take care of me for the last couple of years.
Well, it depends. If you have a patient that you've been seeing throughout, in your office, and you happen to do geriatrics and you do long-term care, then
Mm,
you're fortunate enough that you have that patient. If you're fortunate enough and that patient comes to one of your facilities, you can follow them for the rest of their life.
mm,
But if they go to a facility where you're not, where you don't have privileges or you don't go to, then you would not be able to follow that patient. So they would be assigned a different doctor. Most of my patients I've had for quite a few years. I will say a lot of my patients. Um, but yeah, but it is, you can have a different physician.
Hmm.
Yeah.
So, how beneficial? I mean, when we had Dr. Goldstein on a few weeks ago, and he's more involved in pain management. But
Hmm.
one of the things that we discussed in in that conversation was the absolute need for empathy and understanding when we treat patients. Have you, especially since you're a DO, and if you could, when you give your answer, could you explain a little bit the difference between a DO and an MD? Have you noticed that as a DO, you are more inclined to provide that physical uh, connection to your patients, meaning like a hand on the shoulder, or just like you said, in PPE, holding the hand of a patient just so that they know that they're not alone?
I wouldn't say that as a DO, I'm more inclined to do so, and I'll tell you the difference in a minute. I think it depends on the person because
Hmm.
I've worked with MDs who are very empathetic. I
Yeah.
actually just had a palliative care fellow from an MD fellow from another institution, and one of the most compassionate young doctors I've met,
Mm.
and he's an MD. So I think it's more of an individual thing. I think with osteopathic medicine or approach, and we're taught more whole person care. So again, every part, if you have a headache, for example,
Hmm.
it might not just be your sinuses. Maybe you
Right.
have a headache because there's some stresses going on in your life. So we're taught to address every aspect of that person.
Hmm.
And I like to think of osteopathic medicine as we do everything that the MDs do, and then we have
Yeah.
a little cherry on top and we do a little extra. So really what osteopathic medicine is just an approach to care, and it's that whole person approach to care. Some people say osteopathic physicians are more empathetic. I think it's more of an individual thing.
Yeah.
And I think all physicians, when you choose medicine as a profession, I think most people, medical students, when you ask them in their interview, why did you choose medicine, or why do you want to be a doctor? And the number one answer still is, I want to help people.
Yeah.
So,
That was actually one of the major reasons why I got into biological research. The other
mhm.
reason was biologists got to sit while
Oh,
most other scientists had to stand at the bench. So
yeah,
then I learned that at the college level, you have to stand all the
yeah,
time.
yeah. They'll
So,
get you a standing desk.
yes. So, a question, because as I said, I come from a genetic background in terms of
Mhm.
science. So how have you seen the availability of, let's say, services like 23andMe and ancestry.com's DNA? How has that hindered, and how has that benefited you, if you have encountered it, that is?
So, I think it can only help, because it's always good to know where you come from. And for
Mhm.
some people, it unlocks a lot of things, of unanswered questions.
Yeah.
My geriatric patients, I'll be honest, I haven't had a lot of them who've been interested in it. Not to
Mm,
say that the geriatric population aren't interested, but a lot of my patients just haven't done it or whatever. Um,
there.
but I do think that there can be a lot of benefit from it because, for one thing, in terms of things like certain diseases,
Mhm.
knowing your genetics, that can only help. And we've come a long way, like you said, with gene therapy and everything, and that sort of thing. Um, so I I think there is a place for it. My patients personally, they haven't really shown, not that they haven't shown an interest. To them it's more fascinating as opposed to how is it going to change, my
Yeah.
life, my health, and things like that.
Well,
Yeah.
I know because again, when I was in college, that was just starting to become a very big thing.
Hmm.
For context, I have a bioinformatic master's, so
Nice.
thank you. Uh, One of the things that we had to do in that graduate training was we had to learn the context for all of those different genes. It's not just,
Mhm.
oh, you have a genetic predisposition for this because it shows up because of that one allele. It's, well, you also have to look at the inheritance of the subject. You have to look at what their previous generations presented, but
Right,
it's not just the previous generations. You have to look back almost four or five, because some genetic disorders, they
right.
require several generations before they even start developing
They
some kind of
express.
symptomology.
You're right.
Um,
And
yeah,
exactly. Yeah.
and one of the biggest things that I've seen, which I think is a good service, at least in the start, is the genetic counselor
Yes.
profession, because it's
Mhm.
providing that kind of merger between the bioinformatician, the geneticist, and the doctor. It's
Absolutely.
allowing people to get the context that they need for those results. So,
Mhm.
uh, for a bit of context on this subject, a friend of mine had gotten their 23andMe, and then they're like, I don't understand any of this. And I'm reading through their results. I'm like, okay, you might want to talk to your doctor about this, but only as an optional thing. It's not really something that you can really see unless you get something that trips this. And then
Mhm.
I reached one gene that was saying that it was suggestive of um, what was it? It was an increased susceptibility to Lyme's disease, and I went, that
Oh.
makes absolutely no sense. This makes absolutely no sense. And I said, did they give you a secondary email that referred you to a genetic counselor? And she said no. And I went, well, my first thing to say would be print this out, hand it to your doctor, and have a nice conversation with your doctor about this.
Yeah.
That it's going to give you some basic information about what these potential predispositions can be. But then my next statement was, you need to see a genetic counselor because they're going to take some blood tests. They're going to provide a little bit more context to this. They're going to want to do some extra testing, which I can't advise you because I don't have that information in front of me. I've got a secondary report here. So that was one of the major reasons why I wanted to ask you that, because now they're sending all of this information to the
Mhm.
recipients. They're not just sending them their ancestry profile anymore. They're actually sending them the
Yeah.
full
What
report
diseases they may
almost.
be. Yeah.
Hmm.
And the question is, what do you do with all that information? You
Right.
know?
She came to me because she's like, well, you did genetics, and it's like, yes, I did. That's kind of my thing. And she hands me this, and it's long. I don't know if you've ever seen one, but it's a lot of information to throw at someone that has absolutely no idea
Right.
what's going on. And in a way, I almost think that it's unfair. So that was kind of why I wanted to know, because I wondered how someone who is a geriatric patient, that can kind of be overwhelming for them.
Right. And the truth is, for that geriatric patient, does it really matter that your great grandfather had some sort of
Hmm.
genetic condition? You're 95 years old and you don't have it yet. So maybe for your children it might matter.
Hmm.
But for that person in particular, I think that's why I haven't really seen them focus too much on it. So for
I
their
see.
children, it might be important, but for them at 95 years old, they they say, well, a lot of them will say, well, I don't think I've made it through not to age 95.
Mm,
you know. So maybe that's why they haven't been as interested in getting it.
mm. So, another question from our audience here. How much have you encountered ageism in your field? I recently encountered my first doctor who was younger than me, and it was a very odd experience.
Mhm. Yeah. Sadly,
I know that sigh.
yeah, that's right, because sadly I see it happen.
Hmm.
Um, you know, Even with trying to train, young doctors, students, trying to train them in geriatrics, very few of them want to go into geriatrics, first of
Mm,
all. It's not a popular field for medicine. so, so even immersing them into like nursing homes,
mm,
sometimes they'll say, oh my God, we don't want to go there. There's old people there. I'm like, well, we're all gonna get there at some point in our lives. What but
this will be
unfortunately, I
you
have seen
one
it. Yes,
day.
this will be you, and we have to learn how to take care of them. And also,
Yeah.
I also want the young doctors to know how to take care of me when I get to that point.
So there is a little bit of a selfish motivation
There
there.
is that selfish motivation. But all the adults, they are just the best.
Mm,
They you learn, I always say, even though I'm a geriatrician and my patients, they look to me for certain things, but you also learn so much from them.
yeah.
They have a wealth of knowledge that they pass on to you. They have a lot of stories that they tell that you learn from, and their life experiences, and they've paved the way for us in so many ways,
Mm,
and the things that they've been through, just they've paved the way for us in so many ways. We should really
yeah.
just be grateful to a
Well, I
lot of
mean,
the older
if I
adults.
remember correctly, there was a project. I think it was the Smithsonian that was doing it, and what they were doing was they were basically putting um, senior citizens in front of a microphone, and they were just letting them tell their stories, their personal experiences through their lives, and they were
Yeah.
recording it because we're about to enter a generation where young people, I believe, that are being born right now will never be able to meet a Holocaust survivor in person.
That's right.
They'll never
That's
be
right.
able to meet someone outside of like a great grandparent who was in Vietnam.
Hmm. Yeah,
So these are very, very difficult and, not necessarily life altering, but these are culture altering
they are.
experiences that are now, going to be taken for granted, similar to reading the letters on a History Channel documentary from the Civil War.
You're right.
And how much of your patients are just sometimes just telling you stories about things while you're necessarily doing something that might be mundane? And I know that for me, one of the things that helps me with like getting a shot, because for me it's very painful, uh is I'll get into a conversation with the tech because I know that will distract me from what's going on.
Hmm. Oh yeah, my patients, I mean, just about every day that they come into the office.
Mhm.
For some of them, I one of the patient told me just last week, she said, you know, I know I'm coming in to check on my health, but this is also a social visit for me because this is the only place that I go during the week.
Talking
And I
gossip.
right. And I said, well, you got to go out more, go to the Y, do some other things. She says,
Hmm.
I know. But yeah, I mean, they, a lot of times when they come in, but the stories that they tell also helps you with their health because it
Yeah.
tells you about their lifestyle, what they
Hmm.
do on a day to day basis, how they approach certain things. And all those things are incorporated into their medical history. One of the
Yeah.
things we have our students do when they're on a rotation with us, and this is probably the only rotation where they do this, but we do a spiritual history.
Hmm.
And the spiritual history, it's not just about religion or church or anything like that. It's really more about what gives your life meaning, who are the people who are important to you, how would you like your health care to be addressed.
Yeah.
And one of the patients, she said to me, nobody's ever asked me those questions before. Why? And I said, because you're just as much a part of your health as I am.
Hmm.
And we have, we're doing this together. And without you, it's not going to work.
Well, no,
So,
it's very interesting that you say that because after my dad passed away in 2018, we
mhm,
went to visit his sister, his older sister, and there were stories that she was telling me that I had never heard before. I had lived
yeah.
with my father all my life, and at a certain point, I was making a joke with my wife
Uh-huh.
because everyone was telling her the stories, not me, and it's like, whoa, 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 it's my dad. I want to hear about my dad.
Right. Yeah.
So, it it's the context that
Yeah.
comes with the health, and that's one of the things that I try and tell younger students whenever they're learning about research. Part of what you're doing is you're providing the context that eventually some doctor or some clinician or some clinical researcher is going to look for that will give them the answer or maybe lead them to the answer, um,
Hmm.
that will provide help to a patient someday, potentially.
I
Um,
agree.
so that kind of leads me to another question: how has research and medical research influenced you as a physician, a a caregiver, a fellow gossiper.
So that's right.
How has all of this kind of affected you? You know, because research is changing daily. You know,
Yeah.
a new like 15 new articles comes out every hour, I think is what it is. So,
That's true.
how does new research affect you in your practice?
Yeah, so everything we do in medicine is what we call evidence based, and I'm
Mm-hmm.
fortunate in that I'm at a medical school, which means that we have to keep up to date with the information so that we can teach our medical students. And
Mm,
I enjoy it because the students themselves, they bring new information to us.
yeah.
When we do wrongs, clinical wrongs, we talk about the new treatments that are out there, and we sort of, review journal articles. Um, there's grand rounds and all those things. So really, I mean, a lot of what we do in medicine really should be evidence based,
Mm,
and new research it's happening every day. And it might be that the treatment that we have today might be totally archaic. It might not even be in vogue 20 years from now, you know. So I definitely, I mean, I'm all for it, and we do have to have some flexibility to change
mm,
because um, I remember when, for example, I'll give you an example. Even things as simple as wound care, and I do a lot of wound care. The treatments that we have now, much
mm,
different from what we had even 20 years ago.
yeah.
So I definitely think that as physicians, as clinicians, as researchers, we have to stay up to date with medical research. And we're really doing a disservice to the profession if we don't.
Mm. So, I know that in the last, let's say, 50, 60 years, patient interaction and patient care, which in most societies we term it as bedside manner, has really evolved over the years. And I know that some of that occurred only because, you know, movies tend to inform a lot of Americans about a lot of history from a physician who went by Patch Adams. I believe his name is
Mhm.
Hunter.
Yes.
Um, how has those kinds of changes to bedside manner affected patient outcome? I mean, obviously, treating a patient as a person is obviously going to improve their healthcare, but how has developing more empathy inside of the bedside manner affected geriatric treatment?
Well, I think, with medicine, we do what we call the shared decision making.
Hmm.
For the most part, in the few years that I've been practicing medicine, that has been a huge part of what we've been doing. So I think I've been fortunate in that regard,
Yeah.
where medicine is not so much as that paternalistic approach, but really more how do we again, like I said, that shared decision making. So I
Mm,
think the only way we can have good health outcomes, and one of, well, maybe not the only way, but one of the best ways to have good health outcomes is if patients take an active role in their care.
mm,
I can say, okay, you have high blood pressure, you have diabetes, you have all these chronic health issues, and I'm going to prescribe you this, that, and the other.
mm,
And if you don't go home and you take that medicine, you're still not going to have your blood
yeah.
pressure treated. And if you don't say, well, I have high blood pressure and the doctor gave me this medicine, but I don't know. I'm going to go home and do something else.
Mm,
That's not necessarily going to help. Or if you go home and you say, you know what, I'm going to take this herbal medicine, or I'm going to take this over the counter stuff, but I'm not going to tell my doctor about it. And
mm.
then you come in and you're in liver failure, and I don't know why you're in liver failure. Well, after diving deeper, oh, you're taking this special tea that you've heard about on the internet. Um, yeah.
Uh, I had a nickel for every time someone said that to me. Well, I found this thing on the internet.
Yes.
No, no, throw it away. No.
Yeah, we found it from Dr. Google.
Dr. Google.
Yeah.
Well, my wife always makes the joke that if you go onto WebMD, you're either going to end up with cancer, being
Yes.
pregnant, or dead.
Yes. Or sometimes all three.
Yes, yeah, that's the good one is when you get all three jackpot.
Yes.
Play the lottery that day. So we were talking with Dr. Balin last week about
Mm-hmm.
different dementias.
Mm-hmm.
Um, and one of the things that we were talking about was how important it was for those patients, even though they may display some mild cognitive impairment, to still be treated as if they almost don't have that.
Mm-hmm.
To kind of still treat them as they are, which they are, still an individual, still have a personality.
Yeah.
Um, how important are these different techniques that are coming out almost daily in terms of the long term care, the short term care for these patients?
Yeah. I think the important thing to realize is that person is not the diagnosis.
Yeah.
We still have an individual in front of us. Sometimes, I'll have students present to me and they'll tell me about the diagnosis in bed, whatever. I said, I don't know about the diagnosis in bed, whatever. I know there's a person in bed
Mm,
12, and
yeah.
what's that person's name?
Yeah.
Describe that person to me, and then we can talk about the diagnosis. But I
Mm,
want to know who the individual is first. So I think, with people who have dementia, and even I would say people, older adults, we take away that personhood from them sometimes.
mm,
And we really need to realize and recognize that there's still an individual in there and they are not the disease.
yeah.
So I'm Nicole Joseph and I have a diagnosis of dementia. I'm
Mm,
not I'm not Nicole Joseph, the dementia patient.
yeah.
You know, um, so I do think it's important to treat them as individuals. Find out what they like. I'll tell you one one of my patients, for example, who she has dementia,
Mm.
and one of the things the nurses says to me, she won't eat. I was like, what do you mean she won't eat? Well, I go into her room and I sit with her and we start talking and what have you. And I said, look, you got all this stuff in front of you. She's like, oh yeah, is this for me? Yeah. I said, it's delicious. And we start talking about the food. And at the same time, I'm feeding her. By the time she's done 100% of her meal,
Mm-hmm.
you know. So sometimes the approach also matters.
Mm-hmm.
I think we should always approach people with kindness and with
Yeah.
compassion and thinking, if I were in this situation, how would I want to be treated?
Yeah. Yeah, definitely I do think that the empathetic approach, uh, which has been expanded on in the last, 20, 30 years, is moving in one of the best directions that it can because again, like you said, it's not the patient in bed 6 has a diagnosis of myocardial infarction. Well,
Mm-hmm.
tell me about the person and tell me how knowing about that person is going to affect the diagnosis and the prognosis as a whole.
Yeah.
And that's one of the things because I have two medical students that are in the lab that I work in right now, and one of the things that or excuse me, three. One is a DO PhD student, and one of the things that I kind of hammer into them is I tell them the experiences that I had in the medical community, both through myself, my father, and my mother, who had breast cancer a few years ago. Um, I said, listen, there are looking at this in hindsight, learn from the mistakes, but also learn from the successes of these doctors as well, because it's not just about what they did wrong. It's also, and sometimes even more important, about what they did right in
Yeah.
these situations. Um, because and I say this, look, as a doctor, you're not infallible. You are going to make a mistake one day. It is
That's true.
inevitable.
It's true.
Making a
Mhm.
mistake is not a bad thing. You're human. It happens. So, I one of the things that I try and get them to do is confront some of the harder issues early because they'll
Mhm.
have more time to think about it. And I've always seen that giving someone more time to think about that kind of pane of glass that they have to shatter themselves makes it a little bit easier when they finally reach that situation.
Yeah, I agree. I
And
agree.
especially in geriatrics because you probably have a lot of patients that are going in for surgeries,
Mm-hmm.
hip replacements, joint replacements, uh, you know replacements that are even just like major heart surgeries, there's a lot of the parts fall apart. We were just saying,
Right.
the warranty ends at a certain point, and you have to, figure it out. I said to my mother, Mom, this adulting thing isn't working. Where do I turn in my, my warranty card? She's like, it doesn't work that way. So,
Hmm.
how do we as a general populace, how can we better help you as a geriatrics doctor? Other than just educating ourselves, but what can we do that will make it easier for you down the line, other than taking care of ourselves, of course.
Yeah. You're right. Taking care of yourself, that's a big one. Staying informed and
Mhm.
really, I think respecting our older adults also.
Mm.
And, again, and I said this before, but they've had life experiences. They've worked, they've
Yeah.
paved the way for us in a lot of ways. So I think also just staying informed, getting as much information as possible on what it's like for the older adults. And really, we need more providers for older adult care. In the nursing homes, we're seeing shortages when it comes to the geriatric units,
Yeah.
the hospitals, even for the medical schools. Very few medical students graduate and decide, oh, I'm going to choose geriatric as a profession. And,
Yeah.
the ones who do usually cite an important parent or grandparent or
Mm.
family member in their life. I know for me, my grandmother was probably one of the most influential people in my life, and she was the reason why I decided to do geriatrics.
Mm.
Um, but very few medical students and even nurses want to do geriatrics. So, and what's happening is the population is aging. I think
Yeah.
we're projected to have about 50 million by the year 2030
Oof.
and not enough providers to take care of
Oh,
them. So,
wow. Well, I think you
yeah,
said it was something like 6,000 total,
yeah,
correct?
there's only about 7,000 board certified, and I think of
Oh my.
only like 17,000 total. So it's really it's a small number to treat a large population of
Yeah.
people. So if we can get more providers, I think that would go a long way.
Mhm. So, one of the things that we got to talk about last week as well, and uh, I know that you didn't get the chance to watch the episode, but if you do, I think it might be something that you would find interesting as well. Was Dr. Balin and I started talking about the dementia communities and the
Mhm.
senior communities that are forming, even in here in the United States, because we seem to be getting behind on that kind of care. One of the communities that I had heard about more colloquially was, there's a community, I believe it's in the Netherlands, that
Mhm.
houses both dementia patients and patients at the college level, and it allows the excuse me, not patients at the college level, college students, and the college students get reduced or free housing by interacting and spending time with those dementia patients.
Yeah.
Can you give us more of a clinical perspective on that kind of service? Because I can only speculate because I'm, from what I know as a scientist.
I mean, I think that's a great model in that, well, they both learn from each other.
Mm.
That's the one thing. But also for the older adults, it keeps them active.
Yeah.
They have, we have, if, for example, our hospice patients, we have volunteers who come in and they sit with them, they read to them,
Mm.
they play music with them. And that social interaction is so important. I know for our nursing home residents, we have the medical students come in and they're always so happy to
Hmm.
have the students. I mean, they talk to they actually talk about it with me and they say, when is my student coming? And I'll let them
Ah.
know, not until next week, but but they'll tell me, tell that student, ask her if she read that book I told her about. you know so they really do enjoy these interactions, and I think it's also beneficial to those college students because
Mhm.
they're giving back, they're giving something to the older adults that they probably wouldn't otherwise. It makes them more it exposes them to older adults. I
Yeah.
think sometimes the younger generation, they almost have a little bit of a fear of the older
Yeah.
adults, and it removes that fear. So I think that's very important for both
Mm.
parties.
So I know from the research perspective because I work with Dr. Balin a lot and we do a lot of Alzheimer's research. I know that routines are very good for
Yeah.
someone with dementia.
Mhm.
What is your opinion on some of these dementia and Alzheimer's communities and senior communities that almost create miniature towns
Mhm.
uh, in them? How do you feel that that would benefit, and even also some of the detriments to those kinds of setups?
I think it does have some benefit. There's about they talk about the villages and
Mm,
the greenhouse models and all these different models. And in a way, it creates sort of a safe haven for
yeah.
them. And they're in a community within a community, but
Hmm.
they're able to do some of the basic things that they may not have been able to do otherwise, like
Yeah.
grocery shopping or going to the library.
Mm,
When my dad, before he passed, I remember he lived on this development in Texas,
hmm.
and they had a library, they had like a little store, they had medical offices, they had all these things, and you really didn't have to leave your community for anything. And they
Yeah.
had trips and all these things going. So I think it does create a sense of normalcy for them.
Hmm.
And like you said, routines are very good for dementia
Yeah.
patients. You take a dementia patient out of their environment and they get agitated, they get confused, they become scared, and they
It's a
really
bit of
need
anxiety.
routines. They get anxiety. That's
Yeah,
right.
it's a lot of
Yeah,
anxiety. I
it does.
like to, especially because my mom's getting older.
Mm-hmm.
She's now starting to get into her mid to late 60s, and
Mm-hmm.
one of her biggest fears, mostly because of TV and movies, is dementia. You know,
Yeah.
losing herself, and at one point, because my father was a big fan of movies, I said, "Mom, you remember on Golden Pond with
Mm-hmm.
Henry Fonda?" And she
Yeah.
says, "Yeah, you remember the scene when he's in the woods and he knows how to get to his home from the dock, but he just runs a different way and he just ends up spinning around and around
Yeah.
and around and around." She says, "Yeah." I said, "That's what it's like.
Yeah.
It's
You're
not that
right.
you're just going to completely devolve into this a personality person. You're going It's going to be a long stage, and there are methodologies that we can put in place that will
Right.
help you and could even potentially slow down the process. you
Right.
know uh
And she
I'm
might be one of those lucky individuals who lives to
correct.
be 100 years old with no dementia.
Well, she better. She
Yeah,
better. I don't have any kids yet. She's got to see the grandkids.
there you go. And it's funny because I think we think of dementia as a normal part of aging, but it really isn't.
Right.
Dementia is abnormal aging. So
Hmm.
hopefully, most of us would get through aging without ever having dementia. That's our goal.
Yeah, that's true. So how do you, as a geriatrics doctor and a clinician, how do you view the almost the embrittling of the body as time goes on? We always hear about senior patients falling, and now they become much more at risk of breaking something,
Mhm.
or having something rupture, or developing a hematoma of
Yeah.
some kind.
Yeah, in geriatrics, we have this term we call sarcopenia, which is age-related disability,
Mm,
and starts actually probably when we're in our 40s, unfortunately, especially with women after menopause. But you know, the way we slow that process down, again, physical activity, maintaining health. I know I stress a lot about, on being active and
mm,
making sure we have appropriate diets and everything, but really it is part of slowing that whole process down, or at least maintaining health in old age for as long as we possibly can. Is maintaining that functional status,
right.
because we know that people who have poor functional status, they tend to worse. So
Mm,
when they fall, they're going to break their hip. And when you have a hip fracture, 30% of patients who suffer a hip fracture can die within a year, and a
wow.
good portion of them never return their function. So those are high numbers. So if we can reduce frailty in old age, that probably would go a long way towards maintaining functional status. So really, in terms of exercise, the recommended at least 150 hours per week. If we can do a little bit more, I think that's great. And not just cardio, but also strength training exercise. I always say to my patients, you don't have to lift 2,000 pounds to stay in shape. 5 pounds is
Yeah.
okay, you know? And
You can get a pretty decent workout off of 5 pounds.
yes, you can. I lift 3 and 5 pound weights and I do a lot of repetition because on a day-to-day basis, I'm not
Yeah,
lifting 100 pounds,
correct.
you know. So things that we need to do to keep us functional on a day-to-day basis. Climb steps, instead of taking the elevator, take the
Yeah.
stairs. Things like that. So,
So, one last thing that I think might take us to the very end is how has the current climate of acknowledging mental health affected the geriatric treatment? I know that, one of the things that I've been reading, especially in psychology journals, is that the previous generations never seemed to acknowledge a lot of the mental health disorders that we now associate with specific symptomologies.
mhm.
How does that affect you as a geriatrics doctor? It seems almost like you're not just a medical doctor, but you almost have to be part medical doctor, part uh, physical technician, PT certification. You almost need everything under the sun.
Yeah, geriatrics is like a one-stop shop, we call it, right? Yeah. Yeah, mental health it's a huge deal. And I will tell you, our geriatric populations, it's like you said, it's not something that they've embraced.
Hmm.
They always feel, oh, it's a little depression, a little sadness. I've had patients who are nuns, and she told me one time because she came in and she was in pain, and she said to me, Jesus Christ suffered more than that. So what's a little bit?
My
And I
mom
said,
used
yes,
to say something similar. Offer it up
your
as a
mom said it.
sacrifice for the souls in purgatory.
Yes. Well, I said to her, he suffered so that you wouldn't have to.
Right.
So, but yeah, so but I think I'm seeing more that they're open to it. They're open to medication for mental health. They're open to
Mm,
counseling. At PCUM, we actually have the Center for Brief Therapy. And I've actually
mm,
referred quite a few of my geriatric patients there, and they've been willing to do the counseling.
yeah.
Unfortunately, sometimes we do have to supplement with medications, and we do when it's needed.
Hmm.
In our facilities, for example, you know, there are a lot of patients with depression, and we're also seeing a lot of patients who have serious persistent mental illness, and they may have
Mm,
had it in their younger days, younger patients who are now aging in
yeah.
with those mental health issues. And we have to treat them in our facilities or in the offices. So I think because I don't want to say it's trending, but because mental health issues are more on the forefront now,
Yeah.
we're seeing older adults accept um, treatment more,
Hmm.
which
Well,
I think is a good thing.
it's one of the things that I remember growing up with was, you just didn't talk about that.
Right.
You did
Mhm.
not talk about that. Um, there was at one point, and I'm a recipient of mental health care, and I'm grateful for it. It was definitely especially when it came to the grief of losing my father. It was a huge help for me
Mhm.
because without
Agree.
that, I probably would have lost myself. I probably would have retreated inside myself, isolated more, and then that would have been the especially because I read a little too much into scientific papers. It probably would have
Mhm.
been eventually the destruction of my personality as a whole.
Yeah.
Um,
Yeah,
and
definitely.
yeah, exactly. And
I'm a
that
huge proponent of treating mental health disease. I mean, and I think there's such a stigma associated with it,
yeah,
which there shouldn't be. If we have high blood pressure, we're going to
hmm
take that pill for high blood pressure, or we're going to
right,
do a DASH diet and everything else. So if there's something going on, if we're depressed, see somebody, and that's okay. I
mm,
think we need to normalize it
yeah,
and let people know that it's okay to seek help.
I agree.
Um, eh,
I agree, and that was one of the things, and later this week we actually have Dr. Jess Kandorsky,
Okay.
also at PCOM, who's in charge of one of the people in charge of the behavior unit, um, at PCOM, and that's one of the things that I want to kind of get into is how trauma trips these mental
Mm-hmm.
health issues.
Yeah.
One of the biggest things that I've noticed, especially from when I was a young kid to now as more of an adult, is there was always that idea of, oh, I understand that this is a thing and I'm very accepting that it's a thing, but that's not me.
Yeah.
That's not me. I don't need that. And you sit there and you look at it and it's like, you are a textbook example of this. 100%. How can you say that that's not you? And I
Right.
think you're right. I think there is more acceptance of the
Yeah.
idea that we do need to ask for help for things that
Mm-hmm.
in previous years become trauma.
Right.
um, One of the things that I've tried to learn as much as possible is the effect of stress on the human body. I
Mm-hmm.
believe, and please correct me if I'm wrong because you're a doctor and you would have a better idea of this. I believe that when Dr. Martin Luther King passed away and they did his autopsy, when they looked at his heart, he had the heart of a 70-year-old because of the level of stress that he was
That he was
under.
on. Yeah. Yeah.
I mean, do we see that? I mean, is stress really going to cause, if you will, our candle to burn that much faster?
Yeah, I mean, stress has a effect on just about everything. Even in physicians, there's a lot of talk now about physician burnout
Yeah,
and mental health for physicians, and even in that area, there's been that stigma. That if I see treatments, what if the medical board finds out? What if my
yeah,
patient find out? What if my colleagues find out? Are they going to look at me differently? But really, you know and then also the effects of stress on our high blood pressure, not to mention our overall health and everything
mm,
else. I think when we go through these situations, we do have to seek the help that we need.
yeah,
And it's important also to be self-aware and to take
mm,
that time for mindfulness and saying, you know what, today's my day, and I'm going to take some time
yeah,
for me and just reflect on everything that's going on, but realize also, my dad, go back to him, used to say, he used to say, you know what, you didn't make this world, so you're not going
yeah.
to fix all the problems in it.
Oh, but come
So
on, Dr. Joseph, you got to tell me that you haven't sat there and gone, how can I fix this problem?
how can I fix it? And we all have, right?
Yeah. So we have our audience member puts it, a silly, nerdy question for you. Have you read the book Old Man's War by Joseph? I believe that's Scalzi. If not, what would you think of the concept of a 75-year-old patient joining the Marine Corps?
Old Man's War. So I have not read that book, but I just wrote it down because now I'm going to. And I do have a goal to read at least one book per month. So that's
Oh,
going to be
good,
added. One
lovely.
non-medical book, actually.
Well, I've started listening to
Per-
audiobooks when I'm doing work as well.
yeah. Well, it's funny. I can't do the audiobooks because I like, the paper and turning the
Yes.
pages and what have you.
Mm,
But no, I haven't read that book. Um, as far as a 75-year-old joining the Marine, if he's physically fit and he can handle the exercises and everything that they have to do,
mm.
I probably can't because I'm not that fit.
Yes, me
But
too.
if if they're able to do it, then I guess they deserve to be in the Marines.
Mm.
And if they're cognitively and physically fit and they're able to do everything that's required, hey.
No, I completely agree. Let me ask you this because I know that this has become a new avenue of medical science. How has the availability of nutritionists and dietitians assisted in geriatric patients, but not only geriatric patients, but patients as a whole?
Oh, I think they're very helpful. As a matter of fact, for my patients who, for example, newly diagnosed with diabetes or high
Hmm.
blood pressure, one of the things we recommend is that they see a nutritionist
Hmm.
because, again, part of it is our genetics, part
Yeah.
of it is our diet, environmental factors, things like that. So if they can work on those factors, that does make a difference. Um, I think with the obesity crisis that we have, where we kind of supersize everything, you go to a restaurant, would you like, and the glasses are so big, and I'm like, oh, who
Yeah.
drinks that much juice? You know? But I think it's very important, nutrition, and even in our facilities, we have a dietitian who
Hmm.
makes sure that patients have disease appropriate diets
Yeah.
and things like that. So they definitely play a huge role in medicine.
Well, I remember the days of the Centrum Silver commercials
Mhm.
always being on TV. And I mean, I'd go over to see my grandparents
Yeah,
during the day, and it would just be like every other commercial was a Centrum Silver commercial.
right.
And how it always made me wonder how much more important is nutrition to a geriatric patient than, let's say, someone who's in their 30s or even someone who's in their teens.
Yeah. So nutrition is important to all of us.
Hmm.
But for geriatric patients, a lot of times, they don't eat a very well balanced diet.
Yeah.
We have geriatric patients on the tea and toast diet. Again, some of it has to do with income and the social determinants of health.
Hmm.
Some of it have to do with, as they get older, their taste buds and what have you. But as much as possible, my belief is if we can try to get all our nutrients and our minerals and everything that we can from our food,
Hmm.
that is the best way to go.
Yeah.
Because, you know, you can't bottle a well diet, put a well diet, balanced diet in a little pill
Yeah.
and expect that that's going to be enough nutrition for
Hmm.
anyone. For those who can't get enough nutrition from their food, then maybe a multivitamin or whatever mineral or vitamin that they're deficient in, supplementing that can be helpful.
Yeah.
But as much as possible, I say we should try to eat a well balanced diet and get as much nutrition as we can from eating.
This is actually a very good question from our audience. I was actually going to ask something to this accord at some point. How often do you see patients that have that attitude of, I'm not going to be here for much longer, so I'm just going to eat what I want?
I actually don't see it as often.
Hmm.
Um, for most of my patients, at least the ones who come into the office, they actually want to live healthy lifestyles. They
Hmm.
actually they want they want longevity,
Yeah.
but even more important than longevity, they want quality.
Yeah.
They want to be able to play with their grandkids. They want to be able to go on trips.
Hmm.
Before the pandemic, a lot of them used to do a lot of cruises. My
Yeah.
patients loved cruises. um, they like traveling. They like going
Hmm.
to the casinos. They don't like bingo. They tell me, so everybody expects us to play bingo. No, but but they love doing a lot of different things. So I, I haven't seen a lot of people say that.
Hmm.
But I did do have that my 100, I have a couple of people who are in their late 90s who say, I've made it to that age. I want to be able to eat what I want, drink
Hmm.
what I want. I remember I had a patient at 103 years old and she had a fall and the family wondering, why did she fall? Well, they went into her room and they found several 16-ounce cans of beer.
Oh my
Right.
God.
And when she came in, she said to me, I know what you're going to say. And listen, I've lived to be 100 years old. You can't stop me from drinking my beer. And I said, I wasn't going to stop you. I'm just wondering, can you cut down? Maybe just one can today and not 16 ounces because I don't want you to fall, So,
It almost sounds like at times you almost have to be a parent to the
yeah,
grandparent in a way.
yes.
And when my mother was going through her cancer treatment, one of the things that I warned her of, because she had to go through both chemotherapy and radiation, is I said, listen, you're no longer my mother in this case, you're my patient. So you know
Mhm.
I'm in charge of your well-being. That kind of means you have to do what I tell you to do, because in this case I do know better. And
But it's your mom. You never know better.
oh my God, she honestly, it was very much the stereotype of, I said, mom, you need to do this, and she went and did the exact opposite.
That's right.
And it's like, oh, for the love of mom. I handed her a couple of stress balls and I said, listen, you need to squeeze these because it's going to help keep blood flow in your fingertips. And she didn't, and now she's got I believe it's called neuropathy
Neuropathy.
in her
Yeah.
fingertips. And I
Oh,
was like, when she said it and she started complaining about it, my brother looked at me and he said, well, why didn't you do anything? And I gave my mom this look and I went, why don't you tell him what I told you to do? And she went, no, I'm not going to do that.
yeah. I
But
know.
no, it's very difficult. They always say that doctors are the worst patients.
Yes.
It's very difficult to try and help your mother get better when her entire life has been her trying to get you to be better when you were sick.
That's right. That's right.
Hmm. So have you ever encountered those kinds of situations where the patient almost looks at you and says, I do know better than you. I've been around on this earth way longer than you have. You know, I think I can handle this.
hmm Yeah, I mean, you always meet patients like that,
Hmm.
and that's when we kind of sit and talk and say, "I know that, but you're having this problem, and
Hmm.
you've tried all these things, and they haven't helped. Why don't you try it my way? Just give it a try. 2 weeks, that's it.
Just give it a try, my way. Just
Yeah, two
30
weeks.
days forms a habit. That's what they say.
Yeah, exactly.
um, so we're getting very close to the 6 o'clock time, and Dr. Joseph, as I say to my audience all the time, this is done on your personal time, and I greatly appreciate your time. Pardon me, you're actually the first clinician that has joined us on the show, and I want to greatly thank you for providing some of your time and your perspective here. I want to give our audience a few minutes to gather up any last questions that they may have. Is there any questions that you would like to ask me at this time?
No, I just want to say thank you for doing this. And, I think this is a really nice platform you have here, bringing medical information and information on science and research to the community. So
Thank
thank
you.
you very much for having me.
Oh, absolutely, my pleasure, Dr. Joseph. And you're always welcome on the show. And I know that you're going to be joining us at a later time for a surprise that I've been hinting at with our community. So I'm not going to tell them just yet what it is, but we're gonna surprise them with that at a certain time. But I thank you
Okay.
for joining me here today, and I also want to thank you for any future time. But also, please, I hope that you'll one day be able to join us again. Maybe there's something that you've seen in the literature or something like that that you want to share with us, you're more than welcome to come and join us.
Sure, of course. Well, thank you very much.
Oh no, it's absolutely my pleasure. So allow me to wrap everything up, and
Mhm.
then we'll be able to all go home and have a lovely meal with our families. Um,
Yes.
I want to I want to take this moment to thank everybody. Oh, pardon me, for joining us this evening. I hope you guys had fun. I know that we did. If you enjoyed the stream, please consider giving us a follow, as that is the best way to benefit the channel. As well as if you're already following, please join our Discord, as that is the best way for you to find out when we're having streams like this and also when I normally go on stream. Um, if you're watching this on YouTube, please remember to like, comment, and subscribe, as that is the best way for us to get over the hump of the YouTube algorithm. And actually, before we leave, Dr. Joseph, I would like to offer you the floor to basically say any last thoughts that you may have.
Yeah, I mean, if we can end, what I would just really recommend is, again, what I talked about, just preventive health
Hmm.
and maintaining good diet,
Yeah.
exercise, you know, um, maintaining an active level of functioning for as long as possible.
Hmm.
That would be just my parting words.
Yeah. Well, again, Dr. Joseph, thank you so very much. And if you also could, at the very end of your name here, I have CMD. Could you just quickly describe for us what that means?
Oh, it's certified medical director, which
Hmm.
is it's a group of physicians who are certified by the Society for Post-Acute and Long-Term Care,
Mm,
to work with the geriatric population in, say, nursing homes, assisted living,
yeah.
and in facilities. So,
Fantastic. Thank you so much, Dr. Joseph, and
of
I hope that
course.
you'll be able to join us at a later time. And I just want to say thank you to our audience, and so long, everybody. Thanks for all the fish.
Okay.
Bye bye now.
Take care. Bye bye.